Hi, Anne. Good evening.
Hi, Maria. It's great to see you again.
Good to see you as well. And thank you so much for joining me. As you know, you and I are going to talk tonight on this Thursday evening episode of Gynecollege, which is where I get to hear and learn from a lot of smart, competent people about topics in women's health. And tonight we're going to talk about hormone replacement therapy and menopause and what women need to know about how to make a decision as to whether it's right for them. My guest is Ann Steiner. Ann is not only a friend and colleague of mine, but she's a clinical professor of OBGYN at the Perelman School of Medicine in the University of Pennsylvania Health System. She has both a community and academic practice, and that includes her work in a menopause clinic that serves underserved populations of West Philadelphia. She also takes great pride, I know, in training the next generation of competent and progressive menopause practitioners at Penn. And to boot, she's a really neat woman. So I really am grateful that she'll spend a little time with us tonight. And I have asked you myself many questions about HRT and menopause, but a lot of the women listening tonight and their male partners would love to understand just some basic stuff about HRT and menopause versus perimenopause and who takes HRT. Do you take it in menopause only, or is there a role for it in perimenopause? What exactly is perimenopause relative to menopause? Can you shine some light on us?
That's a lot of questions, Maria. So
I
let's.
know. Sorry.
So what's menopause? Menopause is the cessation of menses because you've used up almost all the eggs in your ovaries. There really aren't very many left, and so you stop making estrogen and you stop ovulating and you stop having periods. So that's what natural menopause is. And it occurs around the age of 51 or 52 in the United States. So the perimenopause is the time leading up to menopause where women may experience symptoms of menopause and they may have irregular periods, but they still continue to get some periods because you're not officially in menopause till you haven't had a period for 1 year. So really, you're looking back when you make that diagnosis. And until you're a year past your last menstrual period, you're still in the perimenopause. But it can be a time when women are the most symptomatic. And so we take that very seriously. They may have hot flashes. They may have vaginal dryness. We see women having a lot of mood changes. They may have depression. They may start to lose bone. There's a rapid loss of bone when they stop having estrogen. So a lot of things are going on during that time. What we do about it is to first encourage women to maintain a healthy lifestyle so that they age and they go into menopause in a very healthy way. They don't smoke. They have optimal weight. They continue to exercise. They get adequate dietary calcium. They get vitamin D. And they maintain a good frame of mind. They deal with depression and mood changes and just try to maintain a healthy lifestyle, both psychologically and in their bodies.
So what is HRT exactly? If a patient comes and says, I mean, I know what it is, but what are people's options for HRT?
Okay, so I use the term hormone therapy because we're not really replacing hormones. We're not giving women physiologic doses of hormones that would be the same doses that their ovaries and their bodies would make before they went into menopause. What we do when we give hormone therapy in menopause is to give them hormones to get rid of symptoms, to alleviate symptoms and improve their quality of life.
And
So
that's just a small fraction of what their ovaries were making pre-menopause,
right,
right?
because you don't need to give the same levels of hormones that the ovary makes to prevent hot flashes, say, or to prevent bone loss,
I
those
think
kinds
this
of
is
things.
really important, and I think
Mhm.
this point should be really underscored that the amount of estrogen or estrogen and progesterone that women are given to combat symptoms of menopause is a portion, just a small fraction
Right.
and it's just enough to get their bones to
Right,
stimulate or slow down degradation of bone, or stop hot flashes, or reduce hot flashes,
right.
things like that.
And that's a good point, Maria, because that's why we don't measure hormone levels when we give estrogen
Right.
and progesterone in the menopause, because we're not treating to a certain level, we're treating symptoms.
Right. And women ask me all the time, they say, you better check my numbers because I feel not right. And I try to explain that we're not treating a number. If this were thyroid disease, we might be treating to a specific number.
Mhm.
Um, if this is cancer, we might keep studying biomarkers to watch them drop to see how the chemo is working. But when we're treating menopausal symptoms, we're treating symptoms, not numbers. But I love your idea that that's also why it's not about how much we give, it's about giving a
Mhm.
small enough amount to help the symptoms. And always the theory is that we give the lowest dose possible for the shortest amount of time that people need it, right? You agree?
But but the eye is on the prize of alleviating symptoms and improving quality of life. And we're constantly weighing the risks and benefits of giving hormones in menopause or the perimenopause for the benefits that we are going to achieve. And that ratio changes as women age. So when a woman is very young and has just gone through menopause and we offer her hormone therapy for her symptoms, it's not the same risk benefit as she might experience 10 years later when she may have developed other things like heart disease or have had a stroke or something. And then we have to reevaluate using hormones. So really every year I have someone come in and I reassess their history. I see if anything new has happened. I reassess their cardiovascular risk, their cholesterol on a regular basis, because if that balance changes, then we change what we're doing. It's a dynamic situation. It's not a stamp for life.
Right. And it's not the same for everybody because some women will have inherent genetic risk. In other words, if you have a high risk of osteoporosis and your mom and aunts and grandmothers had
Mhm.
fractures, then we're going to not just be thinking of you as someone we have to worry about hot flashes, but we're going to be thinking of you as someone whose bone health is at risk of rapidly changing after menopause. So
Correct.
a person like that, you might want to what would you do? Keep them on longer, or how would you?
Well, we have a way of evaluating their fracture risk. There's several algorithms we can use.
Right.
And if someone is at high risk for having a fracture, we actually might get a DEXA to evaluate their bone mineral density earlier than 65, which was when we normally do it. So for instance, if you came to me and you said, well, you're 63 years old, but your mother had a hip fracture, I might evaluate your risk with these numbers and get a DEXA on you then, because I would do an intervention. But usually I try to use some of these objective ways of measuring and evaluating to decide this.
Right.
Now, many women are concerned about it, and I really respect that. They'll come in, they're not having hot flashes, but they'll say, I am just so worried about my bones that I really want to go on a low dose of hormone therapy for this. And I think that's appropriate.
Yeah.
We have that conversation. I still look at their risk factors, but I think that is appropriate because 50% of Caucasian women will have an osteoporotic fracture in their lifetime. And it can be devastating. So we really have to respect that risk for women.
Yeah. Yeah, I think so too. That's pretty dramatic. And we know that fractures are a big cause of morbidity and ultimately mortality. So that's one of those silent disease processes that
Right.
is not particularly sexy. It doesn't get the fear factor that breast cancer gets. But boy, women in their 70s, 80s, I think they feel if they could have known that there was something they could do in their 40s,
Right.
60s.
And many of those fractures are preventable. But when you think about it, most women who should be getting a bone density to evaluate their risk for fracture don't get a bone density. Many women who have had fractures don't get a bone density. So we, as practitioners and advocates for women, have to evaluate appropriate screening because really, I don't know if you have any elderly people in your family or, or if you know people who have broken their hip, but if you're older and you break your hip, it changes your life forever. I mean, you have an increased risk of dying in the first year. 20% of those people never get back to their regular level of mobility. They get pneumonia, they die, they develop dementia because their world closes in. It's terrible.
So much of this is preventable, and so few women link bone health to estrogen. Do you agree with that? I have found they're mostly shocked. They think of bone health as just, this is what I'm born with. They don't understand that there's a direct link between estrogen and sort of the
estrogen helps you to build up bone, and it prevents you from breaking down bone. So women, when they go into menopause, will lose about 20% of their bone density in over a 5 to 7 year period. And so the key thing is to go into menopause with a high bone density. And you can do that by maintaining a healthy lifestyle, getting weight-bearing exercise, having adequate calcium intake for your entire life, and adequate vitamin D, because you need the vitamin D to absorb the calcium. But if you don't have those things, and the other thing is really key, 85% of your fracture risk is genetic, and you can't change that. The lifestyle things are important, but you can't change your genetics. You can't change it if your mother broke her hip. So you do the best you can, but I don't think it's appropriate for everyone to go on estrogen to protect their bones. But we have to evaluate everyone.
Right. So would you say that since 85% of fracture risk is genetic, what do you say to a woman who says to you, well, Dr. Steiner, I want to be proactive. I want to do everything I can. And if I have a genetic risk because I've seen this happen in my elderly relatives, why would I not want to have a low dose little estrogen patch from age 52 to when? To 62, to 72? Like, we don't know.
Hard to say, because let's say you go on that estrogen patch and it stops that rapid bone loss and it maintains your bone density. When you go off the estrogen patch, you're going to finish losing it at some point. So it's not going to keep it there forever just while you're on it. So what's important is to perhaps to evaluate your bone density and your fracture risk, and to follow that. And then we have, if women have fractures, if they have osteoporosis, we have many other tools to prevent future fractures. It's not all about estrogen. We have wonderful medications that reduce the risk of fracture.
Right. But as we know, people are loath to take anything they feel has a side effect. That's a whole different topic you and I could talk about for an hour. What about the relationship between hormones and cancer? What do we tell our patients who say, well, my mom had breast cancer, so I can't possibly take HRT or HT, but I am suffering, I'm having hot flashes, I'm miserable, I'm moody, and I want the best thing you can give me, but I'm afraid because my mom had breast cancer. How do you answer?
Well, if your mom had breast cancer, you probably you have an increased risk of breast cancer of some sort, and we can evaluate what that number is. So we offer increased surveillance for breast cancer to women who are really high risk. If sometimes we offer, in addition to a mammogram, an MRI that has its own innate set of problems, but is probably better at picking up small breast cancers in some women. So we might screen you more effectively. But what's interesting is in women who are extremely high risk, like they carry the BRCA gene that increases the risk of breast and ovarian cancer, in those women who don't have cancer but who carry the gene, if we give them hormone therapy in the menopause, they don't have a higher risk of breast cancer than they would have had just because they're BRCA carriers.
That's exciting.
It doesn't increase it more than their baseline risk. So I would encourage them. In fact, I see many women who carry the BRCA gene and they've had their ovaries removed prophylactically. So you can imagine they have early menopause and they're very concerned about the exact thing you brought up, getting breast cancer. But I speak with their oncologists, and we all agree, we come to it as a shared decision that it's fine for them to go on hormone therapy for their symptoms.
Yeah, that's really encouraging because those are women who tend to be very, very worried about cancer, and even if they're suffering from menopause symptoms, are usually very afraid to try that. And so, to me, if a BRCA positive woman is safe to take HRT, then I would think a woman who's has a family history of cancer, to me, that's even one step removed, that they would be safe.
Right.
And while these are obvious to you and I, there's so much fear around cancer that I think it merits stating that.
Well, as you and I and most of our listeners know, is that this fear of breast cancer came from that famous study in the late 90s and the early 2000s called the Women's Health Initiative. And in that study, they saw that women who were on a specific type of estrogen and progesterone had an increased risk of some breast cancers after they'd been on it for 3 to 5 years, not right away. The women who were on estrogen alone, this specific one called conjugated equine estrogen, had no increased risk of breast cancer, even after the follow-up studies 18 years later, or excuse me, 9 years later. So they've gone back and they've parsed that study. It turns out the only women who had an increased risk of breast cancer in that study were women who had previously been on hormone therapy, not the people who were on it for the first time. So there's a lot of controversy about the breast cancer risk, but we're all very cognizant of that.
Yes, yes. And I think that brings up a really good point. In the WHI, how they split they split many evaluations, but one was that estrogen only users and estrogen and progesterone users.
Yes.
And clinicians understand this, but I want the listeners to understand this, that if you have a uterus, we recommend that you use, and you're going to take estrogen therapy, hormone therapy, that you use estrogen and progesterone, because the progesterone is protecting the uterus from sort of overstimulation. That's how how I phrase it. If you have no uterus, if you've had a hysterectomy, you don't need the progesterone, and we simply treat your hot flashes and menopause symptoms with estrogen alone.
I agree. The only indication basically for using progestin or progesterone is in a woman who takes estrogen and has her uterus.
Right. Exactly.
There's some small caveat exceptions, but that's basically the only indication.
Right. And the other reason this is important to say, and I'm probably it merits even saying it again, because progesterone creams and these topical progesterone formulations that people buy online, it's rampant. I mean, I have many patients, and yes, the placebo effect is real. So many of them come in and say, but I feel better on it. But I warn them that there is no data to support what's in that cream, and that we don't even really know. I don't know how you feel about it, but I always am a little afraid when people are taking something that I can't even tell them the dose that they're getting. So
the transdermal progestins are very poorly absorbed. Progesterone through the skin is very poorly, and it was only relatively recently that we could even give it orally. It had to be made into micronized progesterone before it could be absorbed orally. So you opened up that topic of these unregulated hormones, and that has become a huge topic since the Women's Health Initiative. About 60% of women who were on FDA-approved hormone therapy after the Women's Health Initiative stopped taking it. And since that time, there's been a huge growth in this country of the compounding pharmacy industry.
Yeah.
And I like to start this off by saying that I prescribe what we call bioidentical hormones. The ones that I prescribed are FDA approved. But I prescribe estradiol, I prescribe bioidentical progesterone that have been put through the rigors of FDA approval. So we know their safety, we know their efficacy. They come with a package insert that explains all these risks. And I feel that I can confidently counsel a patient or a woman, about what the risks are of this hormone and what the benefits are of this hormone.
Yes.
Because believe me, there is nothing that has no risks and all benefits.
No.
That world does not exist. The problem
weighing it, and I think that what's important is that bioidentical hormones. Bioidentical isn't really a good or a bad word. It's a descriptive word. It's a chemistry word. Bioidentical means the structure of that compound is chemically identical
Mhm.
to what's made in your body, which is
Yes.
wonderful. I mean, I think that's wonderful and probably a benefit or better, but not necessarily. There are plenty of non-bioidentical things that benefit us and help us.
Yes.
So the other thing is I think people believe that bioidentical is something that they can only get through a functional medicine doctor or at some compounding pharmacy, and that's just not true. Most of what's in our sample cabinets is bioidentical, or much.
So somehow compounded hormones and bioidentical hormones got mixed up. And I agree with you. Bioidentical, when I think of it, really means the same chemical structure as that which is made in the human body.
Right.
Compounded hormones or drugs are products that are made from pharmacies that are not regulated by the FDA and by regulating companies, and the drugs that come out, whether they're bioidentical or not, that come out of these compounding pharmacies are not restricted or evaluated for the purity of those drugs, the safety of those drugs, the way they're delivered. The delivery systems have not been studied, and the doses have not been studied. So, and none of those medications come with a package insert. So they can make any claim they want because they're not FDA regulated. They can say, oh, this compounded drug doesn't cause an increased risk of breast cancer, doesn't cause blood clots and strokes, doesn't increase the risk of heart disease, because there's nobody to tell them they can't say that.
Now, just to push back a little bit, Anne, this doesn't mean they don't work. This doesn't mean you can feel better taking a tablet or lozenge or cream or something that contains estradiol or testosterone for that matter. It's just they're not regulated and they're not FDA.
They're not regulated. So
Right.
I think
So
currently
buyer
I do prescribe drugs from compounding pharmacies, but I do it under certain circumstances. I do it when it's a drug that is, or hormone that is not available, that's FDA approved for women, like testosterone.
Right.
There's no FDA approved testosterone, pure testosterone for women. I do it if women are allergic to the FDA approved. And the example of that is natural progesterone. The one that's FDA approved is packed in peanut oil.
Yes.
But if someone's allergic to peanuts, obviously you can't give that to them. So I go to the compounded product, and I can get that packed in grapeseed oil or in olive oil, and it's safe for them. And then the third is if they're allergic to the FDA approved, and then of course you wouldn't give it to them.
Right. And I've even had some compounding pharmacies make things because they actually did it more inexpensively than the patient's insurance would pay for the FDA approved.
Well, I do that too.
Yeah.
I do that for vaginal estrogen cream.
I need my progesterone in olive oil for sure, being Greek, maybe even some feta cheese. I don't know. We'll see.
Oh. Well, the problem is, this is a whole nother topic, but the vaginal estrogens very often are not covered by Medicaid or Medicare.
Right.
And the co-payments or just paying out of pocket is unbelievable, astronomical.
Yeah.
So if I prescribe vaginal estrogen cream from a compounding pharmacy, it's much more affordable for my patients. And I don't have a problem doing that. I just tell them it's not FDA regulated for safety.
Yeah. I don't either, because the alternative is they're not going to get it.
Not going to get it.
Right. So I feel like as long as I'm clear with them and I tell them I'm using the same dose or the closest thing I can, I do believe it's basically safe.
But again, it's risk benefit.
It is. What didn't I ask you that you feel is kind of an important thing about HRT or about menopausal
Well, just can we go back to the perimenopause for a
treatment?
minute?
Yeah.
Because I think that was one of your original questions. And we said that the perimenopause can be one of the most symptomatic times of the whole transition, and that women can have terrible hot flashes and still be getting their period. But the problem is, if we use the doses of estrogen that we use in the menopause for treating hot flashes, it doesn't suppress ovulation and it doesn't prevent her period. So she could still continue to have her periods and have irregular bleeding with those doses.
Yeah.
And she could even get pregnant,
Yeah.
at that point in time. And we'd be giving her hormones that we wouldn't give to a pregnant woman. And so how do we treat those hot flashes in women who are still having periods? That's where the birth control pill comes in.
Right.
It's a wonderful, wonderful thing. It's an off-label use of the birth control pill, but it does a lot of things. It suppresses irregular bleeding. It gets rid of your hot flashes. It helps you with your mood. It sometimes helps menstrual migraines, and it can do a lot of great things. Now, we do have other things that are non-hormonal for her symptoms. We have an FDA-approved SSRI for hot flashes, paroxetine in a very low dose. We have some medications that are off-label, but they're FDA approved, like gabapentin and oxybutynin, which can help hot flashes. They just aren't approved by the FDA for that indication. Also, there's some pretty good data about using cognitive behavioral therapy for sleep and hot flashes and night sweats.
Yeah.
So that's something that's interesting that we can try. And lifestyle changes. I mean, I have many women who come in and say, I have that glass of red wine on Saturday night and I just flash all night. And I say, okay, risk benefit. You can have your glass of red wine and not sleep that night, or you can not have your glass of red wine and, it's your choice. Nobody ever died of a hot flash,
Right.
They disrupt your life, but you don't die of that.
So I had a patient who came in and said, I don't want to go without my red wine. I love the relaxation at the end of the day of that beautiful red color in a beautiful glass. I said, you're going to buy pomegranate juice and some sparkling water. Make yourself a cocktail with that.
It'll look just the same.
It'll look beautiful. And I said, you may even have lower calories. She was thrilled. She called me and said, yeah, I did it. I had no hot flashes and I had this great drink. So sometimes we have to problem solve.
Or you can have the glass of red wine and smell it, but you just don't drink it.
Right. But I think you're right. The low dose birth control pill. I'm going to presume you mean low dose birth control pills.
Yeah, we have very low dose birth control pills now, but there's still more estrogen than is in the estrogen we use in the menopause.
Right. But it's the right amount for that transition period.
Exactly.
So if you're 47, 48, having all these symptoms, still having periods, and you haven't really gotten a satisfactory response from a clinician, or you're not sure even to bring it up, advocate for yourself, and ask about the use of a low dose. And don't think of it as a birth control pill, even though it is. Think of it as a perimenopausal segue band-aid mood stabilizer helper, because it's used for all of that.
And you just said mood, and Maria, we really need to emphasize this. Women during the menopause transition develop sometimes severe mood changes and depression. It's really not so much after menopause, after the final menstrual period. It's during that transition period. And we have to be very cognizant of that as healthcare providers, and to help women with that part of their quality of life. And sometimes if you can prevent those crazy hormonal fluctuations that occur on a day-to-day basis, then you're going to stabilize her mood. And the way to do that is the birth control pill, but it's 4 out of 4 weeks, not 3 out of 4 weeks, because you want every day to look the same as the day before and the day after.
That's what I tell them. I draw a little picture with this crazy roller coaster, and I say, this is what you're doing, and we just want to smooth it out a little bit so it's less. We have a question from a viewer. So as long as these questions are general and not, specific. So Don Barnes asks, how long can you safely stay on HRT? Don's happy. I would love to stay on my patch forever. I have no particular risk factors. Anne, what do you want to? answer?
Well, we did mention in the Women's Health Initiative that if it's combined therapy, estrogen and progesterone, that after 3 to 5 years, there was an increased risk of breast cancer in those women. So I bring that up, but the risk was very, very small in that study. It was about 8 per 10,000 women.
Right.
The increased number in 8 per 10,000 women years. It was not a lot of women. So I think, again, we're weighing the risk and the benefit and quality of life. And what you need to do is to assess whether or not you really need to be on your hormone therapy. Now, the great thing about your patch is you can titrate it and you can see how much estrogen you need. And the way you do that is a couple of ways. You can space out your patch changes. So if you're changing it twice a week, and let's say you change it every 5 days instead of every 3 or 4 days, you're essentially lowering the dose. If you change it once a week instead of twice a week, you have just lowered the dose of your patch. And so you can self-control the dose that you're getting that way. Another thing that you can do, and the pharmacists don't recommend this, but if your patch is what's called a matrix patch, and most of them are, as opposed to a reservoir patch, in a matrix patch, the hormone is actually embedded into the adhesive, and you can cut your patch. And the hormone doesn't leak out. So let's say you have a 0.05 transdermal patch. If you cut that patch in half and change it twice a week, you have just cut your dose in half. Right. You've now got the equivalent of a 0.025 patch.
Now, the question to me is that so many of my patients are so active, so fit, so lovely, and they feel so good on all this that they blink and 52 goes to 60. Now they're 60. And now they've heard physicians say to them, well, you shouldn't be on it more than 5 years, or you shouldn't be on it more than 10 years.
Right.
And I have to say, as you and I know, those are somewhat arbitrary based on data that we've done. That if we look forward 20 years from now, I have a feeling we're going to look back at a lot of the women who stayed on into their 60s and realize there really wasn't an increase in untoward events. But again, it's hard for you and I to be able to have that crystal ball. So,
well, starting someone on hormone therapy, the age at which you do it, is different than deciding to continue it.
No, but I'm asking how long. Could she stay on at 60? Could she stay on at 62? I mean,
I don't have a problem with continuing hormone therapy past the age of 60, as long as you don't have increased cardiovascular risks. Your mammograms have been normal. You haven't had a heart event or a stroke, and you continue to see whether or not you need to be on it. So I think you personally have to weigh that risk benefit as well. So what I would say is, if your lipids are normal, if your health status hasn't changed, and if you feel that you need to stay on it, I wouldn't have any problem continuing you.
Even if no symptoms, like if Dawn doesn't need to stay on, Dawn doesn't have any symptoms. She just loves the fact that
she doesn't have any symptoms because she's on the patch.
Right. But if she comes off that patch at 62 and has no symptoms, but wants to stay on it because she knows that is slowing down the bone issue, that is, I have patients who tell me they feel that when they come off the patch, they experience hair and skin and aging in every possible way. Is it fair for you and I to say, well, that's not really significant, you should only be on it for hot flashes?
We're talking about quality of life here, right?
Yeah.
And we're basically saying that she's telling you she feels that her quality of life is better on the hormones rather than off of it.
Right.
And she has tried without. I respect that because, I don't walk in her shoes.
Right.
And I can check the boxes for hot flashes, sleep, mood, bones, that kind of stuff. I can't check all the boxes for quality of life.
Right.
So I have to.
Gray area.
Yeah.
Gray area.
And knowing, but it's my job to tell her as she ages, her risk of stroke and cardiovascular events and breast cancer all increase baseline by virtue of her age.
Right. But is the HRT increasing them further?
Well, you're opening another little Pandora's box, and I think this is a good time to bring it up. And that depends on how she's getting her estrogen. Because what we have found is that use of the transdermal estrogens, like the patch, the foams, the sprays, the mists, avoid what's called the first pass through the liver. And it's that first pass through the liver, which occurs through oral medications, that can increase the risk of clotting factors, inflammatory factors, and the things that cause blood clots and stroke, and maybe even heart disease. So by giving it transdermally, at least we're optimizing the delivery system in terms of her risks. And there aren't really any good studies about the risk of cardiovascular disease and blood clots with transdermal estrogen. We call them all observational studies. There's no Women's Health Initiative for that.
I know.
And there never will be.
Well, I will tell you that our colleague Jim Simon feels that 20, 25 years from now, we will look back and there'll be a cohort of women who observationally will have stayed on into their 70s and whatever. And he feels we will find that they actually had lower risk of arteriosclerosis and hip fractures and things like that. So it'll be interesting to see. We have another question, so we'll probably let Missy put that up there. How important is supplemental calcium for women with osteopenia and atherosclerosis? That's a great question, right? Because there's
a really important question. Well, first of all, I don't think the data about supplemental calcium and atherosclerosis is very good. I think we have pretty good data that taking actual calcium pills, supplemental calcium, increases the risk of renal stones. But I'm not so sure about atherosclerosis. However, I am not a big fan of supplemental calcium. It doesn't work very well in terms of how it helps your bones. It's not absorbed very well. It gives you constipation and upsets your stomach. And ultimately, it can increase the risk of kidney stones. Now, for osteoporosis, that might be a different story for certain situations. But I think dietary calcium is is the best way to help your bones if you have low bone density. And I have a whole list of calciums in how you decide which foods are the best. And in fact, there's a free app called the Calcium Calculator, which you can download from your app store, and you can use it to figure out how much calcium you're getting in your diet. Now, if you can't get your 12 to 1500 milligrams of dietary calcium a day through your diet, then okay, take a supplement. But what I tell people is don't take large doses all at once. So many of those calcium supplements are 600 milligrams of calcium with some D in it sometimes. I tell them break it in half, so it's 300 at a time, and don't take the halves any closer than every 2 hours. So by the end of the day, you get the whole tablet, but you really can't absorb much more than 500 milligrams at a time anyway.
I always just tell people that there are very few women who truly don't get calcium in their diet. There is so much fortification and so much food. If you just drink orange juice, you're getting calcium. If you have yogurt, you're getting calcium. I mean, it's hard to find foods.
It doesn't have to be dairy. It can. I mean, we have almond milk.
We have so many vegans out there now, and they're getting calcium in other foods. So I make patients go home and write down what they eat and actually look up the calcium in it, like your calculator app. And I never get a phone call back saying, you know what, I need more calcium. They all get it.
You can figure it out.
Yeah. So I don't want to keep you, Ann, and you and I could talk for 6 hours. But this could be like the filibuster of menopause talking.
It is. I love talking about all of this.
I do too. I love talking with you because I learned so much from you, and
thank you, Maria.
bring such a real approach to all of this. If other people have questions, Dr. Steiner is, I can reach her. I have secret ways to reach her. But if you have questions that I can help you with, you can always get me through princetongyn.com, my website. And I feel like, and there's so much more we could say, but I think this has been really good to help people just get some real basic ideas for what they can and can't do, what they should and shouldn't be thinking about, and most importantly, to advocate for themselves and to understand that menopause is not a disease, it's a life chapter, right? and to learn. What you have some closing statements?
I'd just like to say that I can't emphasize enough how important our organization is that brought us together. It's the North American Menopause Society. Their website is menopause.org. They have so much information for women that are interested in menopause and the transition and are postmenopausal. That's where I get my information. I consider them the gold standard of menopause information. And I encourage everyone to use their source. If they're looking for a menopause practitioner locally, they can look for a certified North American Menopause Society menopause practitioner. You just put in your zip code and you'll find someone in your area. We're out there.
Yeah.
But it's been a wonderful privilege to be a part of that organization.
For sure. And that's a great comment because you can put your zip code in and literally find a menopause practitioner. And it is important. All OBGYNs are not the same. It doesn't mean they're not all wonderful and caring, but many are very focused on obstetrics, and others are very, very focused on menopause and really want to listen to you and to help you in an evidence-based appropriate way. So use menopause.org, and that I agree, it's a great way to find people who will give you the answers that I think will benefit you. All right, I think we'll call it a night. I can't thank you enough. Next time we're going to meet with Dr. Jill Barron, who's a colleague and friend of Anne's and mine, who has actually just written a book, which will be fun. We'll be talking about that. And we'll talk about stress and stress management. Uh,
Jill is great.
yeah, and during the pandemic, the topic of stress has become very
Well,
omnipresent.
that's another thing we can talk about is what's happened to women in the pandemic.
That's right. I know, and I think you should come back and we should just do a pandemic thing. But anyway, be well. Good night. Stay well. Take care of yourselves. And thank you so much. Good night.
Good night. Thank you for the opportunity.
My pleasure. Bye-bye.
Bye, Maria.